Can I start? So in India, we have two national level programs where we are supposed to inform them about any adverse event in our hospital. That's a Pharmacovigilance Program of India and the Meteorovigilance Program of India. And please do also inform us at the AIOS Adverse Events portal. So these two come under the Indian Pharmacopoeia Commission, which was originally attached to the AIMS Delhi, and about 4 years ago they moved to their own place in Ghaziabad. So who can report? Any consumer or patient or physician or pharmacist or nurse, anybody who's involved can report. Interestingly, much of the reports are coming from the pharmaceutical industry themselves. About 60% of the adverse events reported to the Government of India are coming from the trade. What to report? You can report any non-serious or serious known or unknown complication. It can be minor or it can be death or life-threatening. So how do you report to the government portal? You have a web page, you have a toll-free number, you have a Twitter handle, you have a mobile app. So it's easy to report. You just Google adverse events Government of India and these various options will come up for you. So about 60,000 adverse events have been reported in 2021 in India. India ranks 9th in the WHO list of adverse events gathered. And we have about 350 monitoring centers, and these are usually the government medical colleges. Now, when you report, the patient details are kept in full confidence, but the reporter's details are all captured. The reports are very simple, and you don't have to fill up every column. Whatever you know, whatever you feel like, it can be reported. The government captures the data. They don't come back to you ever. They monitor the number of reports, and if you have a number of reports about any particular drug, then they decide to take action and they contact the company involved and they interface with them. You have a separate reporting form for medical devices. You have a shock from your OT table. You have something wrong with your phacoemulsifier. Something is not working with the equipment that you use. You have to use this particular form. So those two are as far as the government rules are concerned. How many of you know that we are having an adverse events committee and a reporting site in our own website? Thank you. So you have a green adverse registry link. If you go to AIOS website, you have a small link. When you click on that, it goes to 3 pages. So what we look for is what is actually captured in these 3 pages. We had a recent report of a person who had a mature cataract. He was operated by a doctor in central India. Within a week, he had a mature IOL. 8 days later, he had to reoperate and remove the intraocular lens. Another doctor was lucky. He opened the pack and he found a white intraocular lens, so he didn't implant that. But all these events were not properly reported, and so we could not follow up on this. So please do report if you have 2 or more cases of any adverse event, including TARS and endophthalmitis. Although for large volume centers, it is like 1 or 2 or more events in one theatre or 1 week, the British guideline actually says if you have a run of more than one infection every 350 surgeries, you please consider it to be a cluster. So for a low volume surgeon, you may be having an endophthalmitis once in several weeks or months. But if your endophthalmitis rate is more than 1 in 350 surgeries, please consider it to be a cluster and take action. Infected medical supplies are an unfortunate reality in our country. We see WhatsApp messages. We need to gather this data so that the AIOS can then talk back to the infected supplies. Unfortunately, get blamed on the surgeon, and the surgeon is often the last. He's not the person who actually is responsible for this. So unless we have a large amount of data, we cannot represent the members properly. So what we look for? We look for the source of infection. We look at the OT zoning and sterilization processes. These were covered earlier. We also look at the protocols and the OT practices. So in the first page, we capture details such as the name of the person, the center, what actually happened, a short case summary of the patient. In page 2, we capture information about the instruments and the reprocessing which was done. Do you have included in IA tips? Are any of you reusing the equipment, and how exactly do you clean them? Do you use tap water? Do you use deionized water? Are you using enzymatic cleaners? All the common causes for TARS and for breaks in sterility are captured in page 2. In page 2, the questionnaires are related to the product and the consumables that you use. What drug you use, what intraocular lens you have used, what reduced intraocular pilocarpine, and chemicals and the products used. The team will also look at the registers and the documentation that you have done. This is very important because after you take care of the patient, you may be legally liable, and the legal liability will be strong from your point of view only if you are maintaining proper record of what you have done. So your registers and documentation will have to be done. In a number of cases, Dr. Chandrasekhar and other members have spoken to various centers and helped them to make sure the documentation is in proper order, because in the months and years ahead, these will be argued out in court. So findings in one of the hospitals that we went to was that Cheadle's forceps was still being used. Eye drop bottles were found in the OT area without a cap. OT sterile bins did not have a sterilization sticker. The date of sterilization was not present on the OT bin. Unfortunately, in this run of end off, the patient did not have a discharge summary in their hand. Post-op notes were not entered. This was failure of systems at various levels for which the unfortunate doctor gets blamed. And particularly Dr. Moria, Dr. Uday, Dr. Bhavanakula should be thanked, because they went to this particular center where a government doctor was involved. They saw the patients pre-op, post-op. They saw the post-op and they agreed with the treatment. They guided them. They spoke to the dean. They spoke to the health minister, and they got that particular doctor reinstated. So the committee are taking extraordinary efforts. When you ask them for help, they will come and help you. In one more hospital, one single infected vial of intraocular drug was used in 4 patients, all of whom had multifocal lens implantation done. The other patients in that list who had a monofocal did not have this particular intraocular drug use. They all escaped. So when you share a single drug across multiple eyes, you risk converting one end-off into a run-off end-off or a cluster. So don't do it. Especially in well-off centers, those of you who are well-off, please use one drug per patient. If you are a large volume center with proper protocols, you can share a single drug across many patients, and there are very, very good examples of people who are doing that well. But then it doesn't apply to 99.9% of the doctors in India. We cannot do that. So all of you who are on low volume centers, don't share your drugs across more than one patient. So we don't want to face a problem like this. Please do contact the zonal members. Please do contact Dr. Santosh Hanover. Please do go to the AIOS website. We'll be happy to help you. Thank you.
Thank you, sir. That was, I think, an excellent information. I just had one question. What happens after the report? What is the next sequence?
So we are not able to follow up on each report, and the reports are generally we have to see whether if you have multiple reports, then usually some action is taken. For example, one particular doctor which is currently being investigated had a series of about 15 patients over a period of 2 months where she had problems. So we are taken samples from that particular hospital, and we are having the various tests done. Till now, most of the tests have come out as normal. So once we find out a problem and we are able to analyze, like we found with the Sunways product, with the intraocular pilocarpine, we will send an advisory. So if you find multiple centers having the same problem, or several samples of the problem occurring in the same hospital, we will take action. As of now, we are not taking any. We are just observing when we have reports from any one center with one or two infections or tasks.
Thank you, sir. That's very useful.
Advisory will be sent.
Yeah, it's very useful to hear that, because as you said, we need to have information from multiple sources. We cannot do any change with just one source. Yes. So this is very good that we can collate this information and then approach.
So this will work only if everybody is willing to